This program demonstrates how nurses and others can assess pain in older adults at all levels of cognitive status and ability using 4 different tools: the FACES Pain Scale, the Numeric Rating Scale, the Verbal Descriptor Scale, and the PAINAD.
Pain is not a normal part of the aging process. Certainly it's associated with things like osteoarthritis, which is, prevalent, certainly pretty high prevalency rates of osteoarthritis in older adults that can cause pain, but it's not a normal part of aging. There needs to be a plan in place, and it needs to be discussed with that patient as to what they want to do, because patients are very reluctant to think about taking a narcotic or adding another pill to their regime when they're already taking a large number of medications. Mrs. Kelleher is a 77-year-old female who's been a resident here at Village Nursing Home for about a month. And she came in with a primary diagnosis of a knee injury. I guess she did have a fall. She did not sustain any fractures, although she has history of knee replacement and hip replacements. And she came here with some issues with pain. She's also a diabetic, so she has some neuropathy that we're aware of. When she first came in, we had ordered Percocet, 2 tablets for her to get that 30 minutes before therapy, really to facilitate that and hopefully get her moving some more. And she also has an order for Percocet PRN as needed.
Could you tell me about your pain today?
My pain this morning when I got up, it was at least a 5. A 5.
How's your pain now?
My pain is it's good, and it's not bad. It's not good, not bad, but it's good because the nurse had given me my medicine.
Okay.
She says I should take it now because I'll be going for therapy later.
Okay.
And I'll have less pain when I go down.
Okay, I'm a little concerned today because earlier today you were rated on the pain scale as a 2.
Yeah.
And you're saying 5.
Yeah.
Is there something we could do to help alleviate your pain?
No, I don't want to take any more medicine. I don't want to take any more, only what I'm taking.
Okay. I'm going to use another scale today just to see how you are with pain. If I ask you a question, could you answer it for me?
I hope so.
Okay, could you please describe your pain from no pain, mild pain, moderate pain, severe pain, or pain as bad as it could be?
Moderate.
Moderate pain?
Yeah.
Could you tell me some things that you've noticed about Miss Keller that helps her with her pain?
Sometimes I ask her if she wants to lay down in the bed, and she say yes, and I put the pillow under her leg to make her comfortable, and she feel better.
It seems if I walk in the hallway, with the walker, with that rotor thing, it eases the pain when I walk, like I'm exercising.
Yeah.
That's nice.
I'm exercising.
So the medication we give you before therapy, do you think it works for you?
Oh, it does. It does. It works for me. Yeah.
It helps you with the pain, so you could...
Yeah, but I don't want to take a lot of medication. My kids don't like me to take a lot of narcotic medicine.
The Try This for pain assessment in older adults focuses on 3 screening tools that we use for self-report of patients' pain. So the first tool is the Numeric Rating Scale, which is a scale that asks patients to rate their pain on a scale of 0 to 10, 0 being no pain, and 10 being the worst pain that they've ever had. And that's a very common scale that's used across settings in patients of all ages. The second scale is the Verbal Descriptor Scale, and that asks patients to describe their pain based on a qualitative description. So you ask patients to rate their pain, whether it is mild, whether it's moderate, severe, or the worst pain that it could be. And then what you can do is you quantify their responses. So you can still use a 0 to 10 scale when you're following the screening and or the evaluation of any intervention. The third scale is the revised FACES pain scale. And with this scale, the nurse or other health professional that's using the scale has a card with a visual image of faces of varying degrees of grimaces. So it is from 0 to 10, 0 being a happy face and 10 being a very, strong grimace. And you ask patients to select the face that best describes what they're feeling. Patients who report pain levels of 7 or higher, you're certainly very concerned about. And at times when you begin to manage somebody who has pretty significant pain, you can actually have protocols that would provide an intervention and then another intervention if the pain remained at a level of 7.
My name is Israel Cassiano. I'll be your nurse today. This is Michelle Maxwell. She's the new employee at Village Nursing Home. How do you feel today?
That's okay.
I've noticed you a little uncomfortable. Are you in pain?
Yeah.
Okay. I've noticed the nurses have been using the face scale. If I show you the scale, could you show me on the scale what your pain is?
I guess this.
Okay, so you're saying your pain is an 8. Is there anything I could do for you at this present moment to help you with your pain?
Just get my medication quickly, please.
Okay. Let me go get your medication. I'll be back in a few minutes, okay? Relax.
Thank you.
So you might have an order that would say to medicate the patient with 1 Percocet, and then if the pain is not relieved within 30 minutes or the pain did not go below a 7 within 30 minutes to an hour, that you would give an additional Percocet. But pain upwards of 7, we are very concerned about and would want an immediate intervention for that patient.
Well, thank you.
Miss Verbe, could you tell me on the face scale how your pain is now?
I'm about here.
So you're getting some relief from the pain medication?
Definitely, yes.
Is there anything else we could do for you?
I don't think so.
The use of these 3 self-reporting tools can become confusing at times for some clinicians who may for some reason believe that the patient is either over-reporting or under-reporting their pain. So it is important to do a more in-depth assessment by the nurse to have a discussion with the patient. For example, if the nurse believes that the patient is under-reporting their pain. And we see that sometimes with patients who have depression and for a variety of reasons. So if the nurse believes, based on other assessments, such as a depression assessment or a behavior assessment, that the patient is actually appears to be experiencing more pain than they're reporting, then that would require the nurse to dig deeper and to talk to that patient. Very often, we do see that nurses believe that patients are over-reporting their pain. And that is something that we really caution nurses about because we really do not have a mechanism to identify that somebody might be over-reporting their pain. The challenges in using any self-report pain assessment tool is having clinicians consistently use a standardized approach to their assessments. So you want to try to embed the screening and the assessment into currently existing policies and procedures, into standardized tools that the nurses are using. So if nurses are using standardized monthly progress notes or admission forms, you would want to be sure to include that. Because if it's not part of a routine and the process of what the nurse is doing, then you will have assessments and screenings fall off, and it won't become just a natural part or a 5th vital sign, as we say. One of the things that I read in the chart indicated that Mrs. Kelleher might have some fears about taking narcotics, some fears of addiction, and she mentioned something about her family, and I haven't had any conversations with her about that, and I wonder if anybody else did.
Well, I did. In working with the patient and the family, I mean, they were starting to tell me that they were concerned about addiction to the narcotics and possibly some side effects, and it really is a concern of hers. So they wanted to know maybe if we could really focus more on the alternatives as opposed to really just looking at the pharmacological aspects at this point.
And you know, I understand that that's a huge concern often with folks and taking narcotics. So it's important for us to make sure that they have the appropriate education, that the risk of her becoming addicted is really extremely minimal. And you know, especially with her neuropathies, I think it's really important that we continue with the Neurontin that she's on, and maybe we can add some acetaminophen. And if we use that in, you know, timing that with the Percocet, I think that when she goes home, we have to think about what are some of the other interventions as well in terms of the medication. At this point, is she? Do you think that she's has some knowledge of the exercise program she's going home with, or where are you with that, Daryl?
Well, I would probably like to start implementing something down on the floor with the CNAs and stuff like that, that they can start an exercise program while she's in bed that would decrease the edema a little bit. Maybe we can do some cold pack or ice and bring that into play on the knees if they're having a little bit more pain at the time, which could help. We could also work with maybe a TED stocking or a compression garment of some sort. Her socks that she's wearing right now, I don't think are compatible with the edema that she's having, so I think something on the TED stocking would be a better implement for her with the edema. We can also train her with a home exercise program, so when she is discharged, that she will have some sheets of paper to take home so that the family and all that can stay on top of that with her at home.
One of the other things that I'm thinking of is that I think we need to be discussing with her about a pain diary and trying to get her to keep a pain diary. And I know, Israel, you used 2 different scales with her. Did you feel comfortable that she was using the numeric rating scale appropriately? I know you had validated it by using the verbal descriptor scale, but do you think we should consistently continue to use the 0 to 10 with her?
Yes, I think it's consistent. I think she's able to let you know about her pain and describe her pain.
Do you think that that's something that she would want to do the pain diary? Could we maybe think about working with her on
Yes,
that?
I could educate her about the pain diary so when she goes home she can keep track of it for the doctor's records.
Right.
So he can know if the pain medication and the interventions are working with her.
Right. And I think it's important also to be able to document what the non-pharmacological interventions are, obviously for her sake, for the family's sake. But I also think that we have to be realistic that she is somebody that has had some pain prior to this, and that, you know, she probably is going to go home with some Percocet. And maybe we could discuss the possibility of her being on a standing dose of acetaminophen and using the Percocet PRN. We should make sure that it's very clear on her discharge papers that she is somebody who has had pain, and talk about this a little bit, that she has been reluctant to take some pain medication.
If I can just add, I'll make sure that I speak with the home health agency and make sure that they're really aware about the compression stockings and her feelings about narcotic use and her reluctance sometimes to take the medications. I'll make sure they know specifically to work with her with those issues when she's transitioned to home.
That's great. And is her family coming in when she's being discharged, do you know?
Yes, they're coming in to drive her home.
Okay. So that might be something else that you mentioned to them, is that we've had these discussions with her and this is the plan moving forward, and just reiterate to them the very low risk of her becoming addicted and how important it is for her to continue to move around and, you know, to manage her neuropathic pain as well. Anything else? No? Okay, thank you very much.
I think in terms of people with dementia, the recognition by nurses that they might be having a problem with pain is extremely underappreciated. And we're just beginning to understand some of the behaviors that might indicate pain. And so there's going to be a lag probably in nurses' understanding of that. But certainly more and more nurses, I believe, are associating some of these behaviors that we see with pain and trying to treat pain. On the other hand, I think they still have a bias about, so if you do see pain in people with dementia, what do you do about it? They are at a loss for what kinds of treatments you might think about doing and how to go about doing that. Today we're going to be talking about an instrument to assess pain in people with dementia, and I'd like to introduce the people as a part of this program. On my far right we have Yi Yan, who's a student, and Mary Miner, who is a hospice nurse, and Rebecca Scobie, who is also a student. So we're going to be talking today about the PAINAD, which stands for Pain Assessment in Advanced Dementia. And Mary Miner uses this instrument in her clinical practice. So we're going to be looking at a few video clips of people with dementia and talk about the PAINAD specifically and how we would use it to assess pain.
In the PAINAD scale, we have 5 behaviors that we assess the patient for. The first one is breathing independent of vocalization. So you might be looking for something like rapid breathing, people holding their breath, just any kind of different kind of breathing you want to really pay attention to when you're working with the patient. The next one would be negative vocalization. If someone were moaning or yelling out or crying or swearing or those kinds of things, those are all signs of that you would take note of. The next one would be facial expression. People that might be grimacing or scowling or any change in their face that would lead you to believe that something is distressful for them. It might be a look in their eyes. It might look fearful. Just anything out of being pleasant you would watch for. The next thing would be we watch for real closely is for body language. And I think you're probably all familiar with that. It can be, they could be very tense. They could be fidgeting in their chair if they're sitting up. Easily just looking away, and just those kinds of things that you would watch for with body language. And the last one is a little bit more difficult to assess, is the consolability. When these people are exhibiting behaviors that you think might be painful, can you console them? Can you distract them with you're comforting them, or are they totally inconsolable? And you probably have all seen that too, where someone is in so much pain that they just continue the behaviors of crying or whatever they're exhibiting. Continue the behaviors of crying or whatever they're exhibiting.
Mary, I wonder if you could say a little bit about how the instrument is actually scored, what the scale is for each of the items.
Well, each of the items, there's 5 items. So, and they're all scaled. Each one is scaled 0, 1, or 2. 0, of course, would be normal behaviors. And then the 1 and 2s are depending on how much of the behaviors are exhibited when you're working with the patient. The total score would add up to 10. Or so you have a score then from 0 to 10.
I think to set up the first one, Mary, do you want to, I think actually this gentleman has some score in each of the 5 areas, is that correct?
Yes.
So we'll play the tape and look at the tape and then talk about what we think we saw.
Yeah. Sit up. Why sit you up, David? Sit up. It's okay. It's okay. It's okay. Sit down. I should have a chair on this side. Okay. I think he's driving. I can't tell him back.
Do you want to start, Yi, and tell us a little bit about what you saw in that video?
Using the tool, I assessed the patient's pain score as a 9.
Okay.
I think he is having a severe pain. I will go through all these categories, how I scored it. For the breathing, I think he had little short period of hyperventilation when they're moving him and when he's really growing. And for the negative vocalization, we all heard a loud crying when he's being moved. And the facial expression, I think he has this big grimacing on his face. And the body language, I can see him really being rigid, and he's kind of pushing back when the aide's trying to move him. And for consolidability, I hear the nurse say, it's okay, but he continued his crying. So that's how I scored it. I scored it as 9.
Okay, very good. And I would agree with your assessment, E. I came up with an 8 because I gave the consolability a 1. That's often one that I fluctuate, and so sometimes in my head I'll go, oh, he's an 8/9, depending. And if you were actually there and had more time to work with him, he probably would be a 2 for the consolability. So, yeah, those are the harder to overall are a little bit harder to assess. So you have to just pay a little more attention, and it might even necessitate further assessment on that. Either, for me, it's often when I'll say to a staff person, when you're going to change them or get them up again, I'd like to be with you so I can reassess. So it's not often that I do it on one assessment. Sometimes I have to go a little further, or I might just assess them myself, turn them, or try to maybe figure out if there's a way he can indicate to me where his pain is by doing a gentle hands-on assessment. And I might even say, like say palpate his abdomen or move his arms and say, is this hurting? And even though he doesn't answer, you might be able to tell by his facial expression, oh yeah, this is the source of pain.
How important is it to do this assessment during movement in your experience?
Well, I think it's very important. In hospice, our number one goal is that the patient be comfortable for his quality of life. And I think someone that has to lay perfectly still in bed, that's not really comfortable. And so I always move patients to see if they're comfortable when they're moving. We've all had pain where if we lay really still, we don't hurt. But if anybody moves us, it does hurt.
Okay, this is the second clip that we're going to assess for pain using the PAINAD.
In this particular clip, watch his facial expression and his body language in particular.
Okay.
Put your shirt on, Mr. Waski. Yeah, you have to let go. You have to let go. Thank you. Let go. You have to let go. No. My back. Okay.
Okay, this time why don't we start with Rebecca? Do you want to say a little bit about what you saw on this tape, Rebecca?
Sure. Starting with breathing, I didn't notice he was breathing hard. It's a little bit difficult with a short clip, but I gave that a 0. For negative vocalization, I also was unable to hear him saying anything, so I gave that a 0 as well. And facial expression, He wasn't grimacing, but he did have almost a sad or fearful look, so I gave that a 1. And body language, I think that I gave
that one harder?
A little bit. I gave him a 2 because he did seem to be pulling away when they were applying pressure to his arms, trying to dress him.
Okay.
And as far as consolability, I'm still confused on that one. I'd say I'd give that a 0 as well.
Okay, good. Do you ever find that even though the total overall score on the PAINAD is relatively low, maybe a 2 or 3, that because one particular indicator is very strong, that you might be more suspicious of pain and maybe actually treat the person?
Absolutely, absolutely. Yeah, that's very, very true. And I wonder if that isn't why, in my mind, I play around with some of the other indicators, because his body language was a definite 2, and in your head you're probably saying 2++,
right.
And so which would warrant medication. And so sometimes you think, oh, a pain of a 2 or 3, we don't need to medicate. But in a situation like this, I would strongly consider starting some medication and then reassess. Do that, and or reassess what you just saw even further.
I think one of the first things that I always look for, particularly in people in nursing homes, is how the care is given. And I think you'll notice that it wasn't the most gentle care in the world that we saw on this clip. So one of the first things I would always do is to examine our caregiving and how we're doing that, and try to figure out if there are more gentle ways, better ways we can give care that doesn't stimulate pain so much in people. So Mary, could you talk a little bit about how you would think about medication, any analgesic medication for this patient?
I would think about starting him on something routinely, and it would probably be a gentleman I don't know real well, and he's probably not been on, I'm guessing he's not on any routine pain medicine or even PRN medicine. So I would, in my brain, think about the World Health Organization analgesic ladder, where you start off with a mild analgesic like Tylenol. And Tylenol is fairly benign, so I probably would schedule that, like QID. And depending on his age and his condition, maybe start even with just a 650. And then you would be allowed to have the PRN dose. If you use the higher range, then you have to remember that there's a max on Tylenol. So I would start with that and then reassess, and then climb up that ladder as needed for his pain control.
So do all the people with dementia have the same pain behavior?
Well, I think as any of us exhibit our behavior in an individual way, that's also true with a dementia patient. And so this is a tool, and this is a guideline for me. And it wouldn't be the only thing that I would rely on to determine if someone is in pain. Of course, you would go to the chart and get the medical history. I talk to family to see what kind of behaviors they're familiar with. If there's no family, I talk with staff. And I try to get everybody's assessment of it, because oftentimes, not oftentimes, but once in a while, you'll get staff, particularly maybe the aides, that will say, well, they always act like that. And so that's, I try to listen to that, but not totally take that as the final answer, because maybe they always act like that because they're always in pain.
The PAINAD stands for Pain Assessment in Advanced Dementia. The PAINAD was developed specifically for clinical purposes, not for research purposes, and it contains many of the important indicators of pain. It's easy to use. Once you're skilled in using it, you can pretty much do an assessment in a minute or two. It's very important that you do the PAINAD or use the PAINAD as an assessment during caregiving, because as you're moving the body, you're likely to stimulate pain. So you want to observe care when it's being given, or give care yourself, and then observe the the older adult while you're doing that. The PAINAD should be done primarily on people with, well, on people with dementia for sure, but mostly people who have either lost entirely their verbal abilities or mostly lost them, where you either can't understand what they're saying or what they're saying doesn't really make sense to you. So in those instances, you would want to definitely use a PAINAD, or the PAINAD. It was developed for people with severe dementia who could not verbally express their pain. But I would say, however, in addition to using the PAINAD, that I like to recommend that you always ask people if they're having pain, whether they can respond to you or not, because sometimes they'll just be in a good place and they're clear mentally and they can say yes or no, or they might be able to shake their head yes or shake their head no. So I always like to do that to give people the opportunity to tell me if they're having pain, and then to use this in addition to that. The PAINAD should be part of a much broader assessment. You don't want to rely on the PAINAD all by itself. So you should be evaluating the person's history, their medical history, whether they have other health problems that would might precipitate pain. You need to talk to family members to see if they have a history of pain, how they handled their pain, how they responded to pain. You would also want to talk to different clinicians or caregivers who are taking care of the person, what kinds of things they observe in the person, and combine those evaluations with the PAINAD. And if you do that, it's likely that you can increase your confidence in whether or not you think the person is actually experiencing pain. The PAINAD can be done by many different professionals with a little bit of training, depending on who they are. I think nurses, other healthcare professionals such as physical therapists, recreational therapists, occupational therapists, certainly physicians, can teach themselves to use it. On the Try This page, there are instructions in how to use it, and there's actually, in addition to the tool itself, there are explanations for each of the indicators and at each of the severity levels. So a nurse could go to that, or a physician or other healthcare professionals could go to that and learn how to use it themselves. How frequently the pain assessment is done depends quite a bit on why it's being done. For example, if you have somebody who has a pretty high score on the PAINAD and you're doing interventions with them to try to get the pain score lower, you would want to do a much more frequent assessment. You might want to do it every day or several times a day. If it's somebody who doesn't have pain, or they have very low pain rating on the PAINAD, and their history doesn't suggest they would have any reason to have pain, you might want to do it very periodically, once a week or once a month, maybe even every 3 months. It just depends on your protocol, but I think also that nursing assistants in particular should, in an informal way, be assessing these behaviors pretty much every day when they're giving care, so that they should be aware as they're giving care, are these behaviors occurring or not, and so that they have a kind of a baseline to know if somebody's having pain. So in that sense, if you're giving care every day, you don't necessarily need to fill the form out and record it in the chart, but you should be looking at it. Also, in acute care settings, you probably are going to do it quite a bit more often, because there are a lot more reasons for people to have pain, and it's generally a pain assessment as part of the vital sign assessment, the routine vital sign assessment. So you should be assessing pain in hospitalized patients as often as you are taking vital signs, and more often if you're giving some kind of treatment, if you're giving medication. You would certainly want to check again after you've given analgesic medication to see how effective it was. And I think no matter what score you get, if you see an increase in behaviors that are on the PAINAD or new behaviors, that should always, I think, prompt a more in-depth assessment about pain, and using the PAINAD and the other assessments that we've talked about. one of the biggest challenges is that sometimes it's difficult to know whether these behaviors that you're seeing are pain-related or they're from something else. Some of the indicators that are on the PAINAD, for example, some of the breathing difficulties and the facial expressions, like a frightened facial expression, could indicate that the person's having a lot of anxiety. And so, or it might indicate that the person's afraid, or maybe there's an infectious process going on, so you don't really know what it means. And so sometimes it can be very difficult to really know for sure whether something's the behaviors are pain related or related to something else. I think that's one of the biggest difficulties. And what we like to do for that is repeated assessments, number one, assess other things, as we've said before, looking at past painful history, looking at physical problems, current physical problems, to see if there is a reason that the person would be having pain or not. And sometimes if you can't find a reason, you might want to give an analgesic anyway and see if giving the analgesic actually helps the behaviors. If it helps the behaviors, then you can be relatively certain that the person does have a pain problem. There are a number of other resources available to nurses in trying to understand and treat pain better than we do. One of those resources is the companion article to this video on pain assessment in people with dementia and pain assessment in older adults. There are two separate articles. Another resource is the NYU Hartford Institute for Geriatric Nursing, and they have a website that has a lot of resources for nurses and other health professionals.
The prevalence of pain in older adults is relatively high. And so what we know from the research that's been done is that between 25 and 50% of older adults living in the community have some persistent pain, and between 50 and 75% of older adults in nursing homes report pain. And those studies have largely been done with patients who are cognitively intact. But there has been a lot of work as well with patients who have dementia. And I know, Lois, that you're pretty familiar with that population.
Yeah, prevalence of pain in people with dementia is actually very similar to people with normal cognitive functioning who reside in nursing homes. It's approximately 40 to 70%. That's what's been reported in the literature. And actually, this population of older adults is at probably the greatest risk of unrelieved pain, because in large part we don't have very good assessment tools, and nurses and other health professionals don't really know how to assess people with dementia for pain.
And do you think that that leads to nurses assessing less for pain?
Well, I certainly do. I think it's one of the biggest problems that we have, is that these people are often, their reports of pain might go ignored, or they're not believed, or the behaviors that they might exhibit that might indicate pain, people, and nurses in particular, are not aware of what those behaviors might be.
And we find even with patients who are cognitively intact that older adults tend to not report their pain. And so when a patient does not report their pain, nurses have a tendency to not ask the questions, or to not screen them if they're not complaining of pain.
That's right.
So,
yes, and sometimes if people are, for example, lying on their bed, or they're quiet, or they're asleep, we go into their room and we think that they couldn't be having pain because they're asleep, or they're not saying that they have pain. So it can be a very largely ignored issue for older adults.
and you know, we certainly want to provide a lot of education and staff education to, you know, practicing clinicians and nurses in the field. But I think one thing that absolutely has to happen is that the tools and the assessment and screening for pain has to really be embedded into policies and procedures, whether it be in nursing homes or in home care or hospice. So we have to have some real standards where nurses are asking patients every day or assessing their pain every day. in the nursing home for sure. And then that also prompts the nurse to, again, if they have a patient who is either sleeping or a patient who may not be complaining or exhibiting what they think to be signs of pain, to overtly go out and ask the patient if they have pain.
Yes, I agree with that totally, Ellen. And I think another issue with older adults is that they're reluctant to report pain because they think that it might mean that they have a very serious problem that they don't want to know about, or they don't want to bother people in the health professions with their complaints of pain. They're afraid of some of the medications, and they're afraid of side effects. So there are many reasons why people with older adults don't like to report pain.
Absolutely. And what we find is that from reports from older adults that when they do report pain to clinicians, it is often ignored. And so at times clinicians will say, well, you know, it's arthritis, or you're 85 years old and you have some pain in the morning. And so patients don't want to report it because they know that nothing is going to happen. And they do consider pain to be a normal part of aging.
Correct.
So it does take education on our part to say pain is not a normal part of the aging process. Certainly it's associated with things like osteoarthritis, which is, you know, prevalent, certainly pretty high prevalency rates of osteoarthritis in older adults that can cause pain, but it's not a normal part of aging. And also to educate clinicians that even if someone is reporting mild pain every morning from osteoarthritis, that that there needs to be a plan in place, and it needs to be discussed with that patient as to what they want to do, because patients are very reluctant to think about taking a narcotic or adding another pill to their regime when they're already taking a large number of medications.
The other thing with people with dementia is that a lot of times clinicians will get used to behaviors that people have. So they'll say, well, that's just their normal behavior. They always act like that. They're always agitated in the morning, or they're always hitting out, or they're always moaning. And that behavior gets ignored after a while because they tend to normalize it, which is a very dangerous thing to do. So
now, do you find that working with families as well and caregivers?
Yes, I think that families and caregivers are also, in terms of people with dementia, they're fairly unaware that some of these behaviors could mean that the person's having pain. So families need to be educated, caregivers need to be educated to, when they see one of these behaviors, that they understand that they need to follow up with something.
And I find that patients themselves are really unaware of a lot of the non-pharmacological interventions for pain. So I think as clinicians, we need to be more proactive in, you know, discussing with patients what a management plan might look like. So it's not just adding another narcotic or another pain medication, and that asking patients how they get relief, because we do know that patients with persistent pain often use interventions that they know work. So it's a matter of, again, discussing that with patients and finding out what are some of the things that we might offer that might help.
Oftentimes, older adults have had pain for such a long period of time that they tend to normalize it themselves, and they might think that nothing can be done about it. And I think with some encouragement often that they are willing to try some treatments for pain that they haven't been willing to try before. But it's an educational process with them as well. They need to learn that they don't necessarily have to live with that much pain and what impact it has on their lives. And they may not even realize it can make them more depressed. It certainly will have an impact on physical functioning. It can have an impact on social functioning, leading to social isolation, can have an impact on appetite and many other quality of life issues that if we could improve those for people, it would make their lives a lot better.
Absolutely. And, you know, we find that very often pain and depression go hand in hand. And what we do know is that when you treat one or the other, very often the patient's quality of life improves. And we sometimes will actually use antidepressant medications as adjuvant therapy to treat pain. So I think it's important as part of our screening and assessment for pain that we do consider whether or not the patient could potentially be suffering from depression, and then potentially do depression screenings as well.
Right. Yes, I think in people with dementia that overlap between depression and pain can be even more complex than people with normal cognitive functioning, because some of the behavioral issues might be the same, and so it's very difficult to tease out, is it depression, is it pain, or is it the combination of the two, where if you treated one, the other would get better as well.
Right. But it really has to be something that is raised at the level of the interdisciplinary team to kind of raise the whole boat and think about this from all different clinicians' perspectives. So what is the role of a recreational therapist? What is the role, certainly, of the physical therapist and the social worker? And I think when you do that, I think, the nurse tends to be that point person, to really be doing that recurrent assessment and to be documenting that and bringing that back to the team to say, I think that these interventions are working, but I think that you really do have to bring in other clinicians and help educate other clinicians as well as to the importance of this. And I think that the importance of getting nurses to use standardized tools, and that's the vehicle to communicate pain, for example, in patients, and that if you were communicating with a physician, that a nurse wouldn't just say, I think Mrs. Smith is in pain. Rather, I did this pain assessment, and Mrs. Smith is rating her pain as a 5 today, or using the PAINAD. And so if you can encourage the use of certainly the try this tools and the different tools that we use to assess pain, that's really the best way to communicate across disciplines, get the best treatment plan.
Yes. I think in terms of education, it's certainly extraordinarily important to educate physicians, not only the caregivers and the nurses, but physicians need to have an understanding about the behaviors too, because in my experience, physicians often relate behaviors to the dementia, and there's like nothing we can do about it. It's just part of their dementia. Well, now we're beginning to understand that there's reasons for behaviors and there's things that we can actually do. But physicians in particular, I think, and the interdisciplinary team, as you mentioned, also need to be on board with what's in the PAINAD and why we think that those behaviors are pain-related. Some of the behaviors that I think that we see, not only in people with dementia, but really a lot of older adults, is declines in physical function. You might see a change in their eating patterns where they eat a lot less than they used to, or they're reluctant to eat, or they might stay in their bed more and not want to get up, might not want to move around. Those are some of the behaviors. We also might see some resistance during caregiving, things like moaning and groaning, facial grimacing, some of the standard things that you expect to see in people that have pain, whether they're demented or not. And so anytime you see these behaviors, it should ring a bell with you that you might need to do some further assessment. In terms of people with dementia, some of the things that we can do to minimize pain has to do with how we provide care. In the studies that I have done, we have found that the way that the care is given really has an impact on how much pain people have. For example, if we try to use real gentle approaches and move people slowly, give people timely warnings that we're going to move their body or that we're going to touch them, often we find that pain is stimulated during care because the body's being moved. And a painful joint or a painful extremity, if you touch it or move it quickly or without warning, it can be very painful. So we always try to look at those care practices first to see if we can modify those and reduce some of the behaviors that we see. So that would always, in my opinion, be our first step with people with dementia, is to look at how we're providing care. Mm-hmm. It's important to think about pre-medicating for people in nursing homes as well. An important time to think about pre-medicating is early in the morning before getting people up and out of bed, because usually, if they're going to have pain, it'll often be exacerbated during morning care when people are getting out of bed, they're getting dressed, they're being turned, they're being cleaned, and so it's a time to think about pre-medicating before all of those activities, and then it can give them a better start to their day that isn't quite so painful.
I think that that's a great point, Lois, and Some of the things that we've done in long-term care is, again, trying to get standard orders written and not having, PRN medication orders for patients who are cognitively impaired, because they're not asking for the pain medication. But if we do know that patients have osteoarthritis and that they are exhibiting some signs of pain on AM care, to get standing orders that are given, just like you said, so you're pre-medicating patients an hour before AM care. The other important factor is to pre-medicate patients for procedures, as we talked about, certainly in terms of pressure ulcer treatments. And again, really to drive home the point of patients who are cognitively impaired, because they're not going to say, stop, this hurts. They may, again, exhibit some of those behaviors, but it's extremely important, I think, to, again, have that embedded in the processes or have those orders already written on the chart. And I think what we do know is that usually a pain management plan has many interventions. So it has to be as I mentioned, an interdisciplinary approach. For example, in the nursing home, one of the things that we often employ is distraction. So the recreational therapists are really very involved and engaged with patients who have persistent pain to distract them from the pain instead of sitting and not being engaged in any activity. Clearly, they're focusing much more on their pain. Physical therapy modalities, certainly in terms of hot packs and cold packs and massage therapy is extremely important. There have been some studies also that support the use of acupuncture, which we have found very successful in patients. So that has helped as well. And I think patients are much more willing to try non-pharmacological interventions because of the fears of addiction and the side effects of the medication, and again, just not wanting to take another pill. So I think patients look to what are some of the interventions, and very often know themselves what are some of the things that have helped them.
One of the biggest problems that we found in our research on pain in people with dementia is that nurses, caregivers, family members are extraordinarily reluctant to give, particularly narcotics, to somebody who is not at the end of life or in a hospice program. So there's a lot of education that needs to be done about what kinds of medications we can use with older adults and to look for the side effects and try to really manage them.
There's definitely a bias. And I think for years, we preached to avoid medications that might cause delirium or dementia in patients. So clinicians shied away from using things like opioids. And then when the studies were done to show that actually opioids is a relatively safe class of drugs with older adults, it was a whole re-education process to say it's okay to use opioids, again, in low doses and, certainly with certain standards. So I think it's been tough. I think that there is a lot of bias about using and adding another medication to a patient's regime.
Which is really an important point, because sometimes what we found in our study is adding an opioid to medication regimen that was already very complex and had medications that caused sedation. When we added the opioid, it might add a little more sedation, and it was just enough more sedation that it really scared people. They didn't like it. Family members didn't like it. And so we had to back off of the opioids when, in reality, the major side effect of some of the antipsychotics is sedation. And so if people are on antipsychotics and you add the opioid, it becomes very complex. And how do you really manage this? And the use of a lot of antipsychotics actually is one of the major difficulties, I think, of treating pain in this population because of the sedation side effects.
Right. And I don't think clinicians necessarily approach the use of opioids in terms of educating patients and families to say this may have a sedating effect initially, but given time that you will feel better and you will not have those sedating effects. So you see exactly what you said. You see patients having a sedating effect, then families and or patients saying this is not where I want to be in terms of my level of orientation and I want to be awake, so then they won't take anything. So then you swing back to having, again, another problem.
One of the things that we found is that nurses and other health professionals are really not afraid of the sedation side effects from antipsychotics, but they are for opioids. It's really kind of a strange thing when you think about it. But I think sometimes if we start opioids, if we really suspect pain and try an opioid, we can often reduce the antipsychotics or, you know, at least take a look at the medication regimen to see, is there something in here we can take out of this regimen so that the sedation isn't so great. And it's a very complex management issue, however, and a lot of the disciplines, including nurses and physicians, get real, I would say, hesitant about changing those kinds of medication regimens.
Right. And I think, you know, most of the pain that we see in older adults is you know, persistent pain secondary to osteoarthritis. That's the most of the pain that we see. That's relatively simple to treat. And when we do get into patients who have much more complex pain management issues, it's very time-consuming. It takes a lot of time. It takes time to not only try different interventions, but to go back and assess. And so it's something that very often today, due to staffing issues or due to an office practice, that there's not a lot of time dedicated to that. So I think that that contributes as well to people, again, not having their pain managed very well.
There's also been quite a bit of, not quite a bit, but there's been some research on people with dementia in acute care settings and how they receive far less pain medication than cognitively intact people. And in fact, sometimes, though, after a hip surgery or other surgeries, they will have little to no pain medication and little to no assessment, really. And I think the dementia piece is an added layer for nurses in acute care settings, that they really don't have the skills for assessing people like that, and then what to do about the pain if they think maybe they have pain. They're afraid to give the medications. They may not give enough, and they think the person is delirious, and so they don't want to add an opioid to the medication schedule. So there are lots of issues in acute care with people with dementia as well. I think a key for nurses in acute care that they could use in terms of their decision making is to realize that most surgeries that people have are going to be painful. And often people with dementia are given no pain medications or very, very little. And so to understand that they need to have scheduled pain medications just like anybody else, and not to just withhold it because they have dementia. Very often people with dementia in particular are going to have an episode of delirium during their hospital stay. One of the things that I think many nurses and physicians and other healthcare providers don't realize is that sometimes delirium can actually be caused by unrelieved pain. So clinicians really need to learn how to assess pain and not be afraid to give medication in hospital settings, because sometimes it can take care of the delirium.
Right, and it's so complicated because what we know is that when patients show signs of delirium, we tend not to want to add another medication that could potentially exacerbate the delirium, or that we're not getting a clear picture of the patient's mentation. So how do you make a decision to potentially add a narcotic that might potentially make things worse? So it is very complex, but I do agree with you that I think that, you know, teaching nurses and other clinicians how to do these objective assessments is really the best way to dig deep and to find out, and of course, you know, interviewing family and finding out what is the real root cause for somebody's either delirium or part of why they're in the acute care setting. Do you find that nurses are not as comfortable with accepting what patients' reports of pain?
Yes, totally. And I think there's a lot of literature actually to support that. When they've asked patients who are cognitively intact to report their pain, and then they ask the nurses how much pain this person has, oftentimes the nurses come up with a far lower number than patients actually do. So it's something that nurses need to learn to get over that. And in people with dementia, it's even worse, because sometimes they're inconsistent. They might be able to use a pain scale one day and they can't respond to it the next day, or they're inconsistent in their responses, or they can't attend to it. So there's lots of complexity when you start adding the dementia, but still I think it's important to ask people, because when they understand that you're really concerned about them and it's obvious in your tone of voice that you want to know if they're having pain, and you give them time to answer, that they will answer you often, even the ones that people tell you are nonverbal.
Mm-hmm. One of the things that we also have embedded into our pain assessments is to ask patients what their goal is for their pain relief, which obviously is much more difficult to do in cognitively impaired patients, but because some patients, don't expect their pain to be completely relieved. And so you want to make sure you have a realistic goal for that patient's pain management plan. So asking them where they want to be is extremely important. And how much are they willing to risk maybe the side effects of adding an opioid? Or some patients will say, I'm okay with a 3 with just the Tylenol. I'm okay with a 3 if I can avoid using an opioid, or if I can avoid adding another medication. And certainly that's part of what we do, is to make the patient the very center of that, developing that plan of care.
I agree totally. And the difference for people with dementia is that often those discussions have to take place with family members. And so family members need to be educated about, how do we know this person has pain? Because it's not something they intuitively know either. And so we have to educate them about the behaviors on the pain ad that we see, and why it is that we want to medicate them, and what we think we want to accomplish, and to get their input also about the goal for the person's care and what they think the goal should be. And I think in people with dementia, that one of the ways that you can sort of institutionalize pain assessment is to train the direct caregivers in looking for behaviors during caregiving activities. So they do need to become very familiar with these behaviors, so that they can notify a nurse when they're either seeing a new behavior or they're seeing a behavior that's escalating over the recent past few days. So the direct caregivers can participate certainly in this assessment, and need to, because they're the ones that are going to be able to actually see the person during caregiving and be able to make that assessment and then notify somebody.
Right, absolutely.